So welcome everyone to the Society of Thoracic Surgeons Congenital Heart Surgery Database monthly webinar. Today is Tuesday, May the 16th of 2023. Thanks everyone for joining. Let's see here. All right, thanks everyone for joining. On the call with me today, we've got from the STS side, we got myself and Emily and Melinda Offer, and we also have Chastity and Leslie, our two consultants. So just a heads up, just a small group today from the STS side. Let me see here. Let me check. Let me see if Dr. Subramanian is over on the nope, I don't think Dr. Subramanian is not able to join today. So thanks everyone for joining. It's myself, Leslie, Chastity, Emily, and Melinda. So let's go ahead and get started. For the agenda today, I just have a few brief STS updates, not a lot of new information from our last call. And then I'll turn things over to Chastity and Leslie for our data manager education. We're going to start with some 6.23.2 new data version information, and then we'll end things as usual with our Q&A. All right. Just real quick, the STS updates, support plan, you guys are familiar with this information. Again, if you have any questions about those analysis reports that were just released or any previous reporting, please reach out to us at the help desk, stsdb_helpdesk@sts.org. Contact updates, contracts, other general questions, invoicing, reach out to us at stsdb@sts.org. And then clinical support, as always, submit those clinical questions via the FAQ clinical question request form. The May training manual is posted. That is available out on the website for you all. And the STS does have a new website, new updated, new and improved website. So if you have any issues locating anything out on the website, please feel free to reach out to me directly. I'm happy to assist in any way. And again, those 6.23 data collection resources are posted out on the website. Spring 23 harvest, again, those analysis results are now available. The official communication was sent on 5/2. There was an updated analysis overview that was posted, and Melanie did post a new one today. It is dated 5/15/23. I had to make a couple of updated corrections, grammatical errors, just cleaned it up a little bit from the previous version that was posted. I apologize for that. So there is an updated analysis overview that is posted now out in the QVIA platform. The most current version is dated 5/15/23. I did get an email from someone asking what updates were made from the previous version, from the previous report. So basically the only thing that was updated in this new overview that was posted is the primary procedure and diagnosis information, assigning primary procedure. So that is where you will see the changes from previous versions. I went in and updated, added the harvest codes for all of the procedures. I included the 5,000 codes that are being considered as PSFs, procedure specific factors. So the changes from the previous version to this most recent version of the overview is specifically regarding the primary procedure and diagnosis information. So again, if you have any questions, just please feel free to reach out directly. The fall 23 harvest is underway, and that does include surgery dates of 7/1/2019 through 6/30 of 2023. That harvest closes September 15th at 11:59 p.m. Eastern. So again, please be sure to get those files in prior to that deadline. Don't wait till that last day, that last hour. Opt out for fall 23 harvest is September the 19th. Public reporting update. Again, this information was included on our last call as well as in the communication that was sent out on May the 2nd. The next data refresh is scheduled for summer of 23. The consent submission deadline for this round of public reporting has been extended to Monday, May the 22nd. And again, just a reminder, this deadline is for those participants that have not previously consented to publicly report their data. So if you have consented in the past, there's no need to send in a new consent. Again, this is just for participants that have not previously consented for public reporting. Consent forms are out on the STS website. And just a reminder that you can withdraw, you can rescind your consent to publicly report at any time. Again, CHSD public reporting update. I don't know, I just have this slide if you want to print it out, share it with your team. Again, the current website reflects the fall 21 analysis updates. The next update is summer 23. We do not have the exact date yet. We will share that as soon as we have that information. And again, the summer 23 update will refresh to include the recently released spring 23 analysis results. We will have another data refresh in fall winter of 23, and that will include the fall 23 analysis results. And then in 2024, we will resume with our annual updates with spring results only. So we'll get back to our annual once yearly updates in 2024. All right, just again, a reminder for those that may not have made the call last time, AQO 2023 will be a virtual conference. The dates for our AQO this year is September 26th through the 29th, with our congenital session being held on Friday, September the 29th. So mark your calendars accordingly. And thank you to those that reached out to me interested in helping to plan our congenital session. So thank you. We got you added to the list, so I appreciate that. Again, mark your calendars for AQO September 26th through the 29th, and our congenital session being held on Friday, the 29th. Also, call for abstracts. Please get those submitted. Official details will be coming soon from Emily. Abstract submissions are scheduled to open soon, mid to late May, and our deadline of mid to late June. And again, the fees for AQO 2023 are listed here. I'm not going to read out all of those, but again, our fees for this year are listed here. Emily, did you have any other information you wanted to share for AQO 2023?
No, just an update about the abstract submission. We're building the site right now to be able to submit. So I would say it'll be opening within the probably like early to mid next week is my guess. And then yeah, just we would love to have some posters, so feel free to submit. That'd be awesome.
Awesome, great. Thank you, Emily. All right, so that's all that I have from the STS side, STS updates. I'm going to turn things over to Chastity and Leslie for our 6.23.2 data manager education. So Chastity, it's all yours.
All right, thank you, Leanne, very much. So welcome everybody. We are going to today discuss a few topics from the new version. I do want to, and I'll say this over and over and over, highlight the fact that these are the new 6.23.2 version definitions that we're going to review. And these do not relate to 3.41. So don't leave here today and start collecting some of these fields with the new definitions. This applies to 6.23.2, which has a go live date for of July 1st of 2023. So again, this does not have anything to do with 3.41. We're going to review a little bit about the training manual, and then I'd like to start with pregnancy complications, the NCAA syndromes and chromosomal abnormalities, and finish up with pre-op factors. Next slide. Okay, so when we look at the new training manual, this will be the front page as it stands right now. And just some things I'd like to point out, which may be a little different from the existing manuals, that there are going to be links within the document, which probably isn't too different, but it will link through other sections, or perhaps even provide bookmarks and links to other definitions and things like that. So hopefully it will be a little bit easier to use. There will also be links to external websites. I know in the congenital training manual, we haven't done a whole lot of that, but Melinda, coming over from the adult side, they very nicely have tables, diagrams, links to external websites where more information can be obtained. And so we've carried those through as well, and then added some additional ones. We're also going to give some examples from for coding. So we know things like operation type, or in a specific scenario that perhaps Leslie and I see over and over in the FAQ box, where we can give some examples for coding. We will provide those as well. It'll be clearly delineated. And also, I think the other thing I would like to add is that aside from the fact that, again, specific to 6.23.2 version only, please do not go back and refer to 3.41 definitions, even though some of the field names have not changed. Many of the definitions have either been updated, clarified, redefined, examples included. And we've used many of your FAQs that have been submitted to drive the new database definitions. So even for those of you who have been doing this for a very long time and you think you know the definition to something, I urge you to, once it gets posted, to go out and look at what the new definitions state, because there could be new caveats and new things to pay attention to when you're coding something, even though we've historically been coding these definitions for a long time. The other thing I would, let's go to the next slide. Okay, so let's start with our pregnancy complications. As you know, based on when you use the field other and you free text things in, or people give us feedback, or you've written in and asked questions, where can I, input this information or that piece of information? We've incorporated those now into the pregnancy related complications field. So you'll see that there are a few new ones, including intrauterine growth restriction, maternal smoking, fetal alcohol exposure, and onset of diabetes. So if you recall, maternal smoking is something we get asked over and over about. People want to include that in the pre-op factors, but we found it to be a better place to include it here in the complication section. And this is just a picture from the data collection form of the pregnancy-related complications we will now be collecting. And then diabetes onset. So while diabetes was a field that was historically included, the onset of diabetes being during pregnancy or even prior to pregnancy will now be collected as a daughter field to the diabetes onset or diabetes field. Next slide. Okay, so just to look at what the training manual looks like, it's pretty consistent throughout the whole manual, but this is just a snapshot. So if you look at, again, pregnancy-related complications, you can see your sequence number, short names, definition, everything is here. And then where there are definitions for any of the variables that you can select, there's a table, and it will then have what the definition is. And so you can see, preeclampsia, hypertension, the intrauterine growth restriction is there. And so that's what the training manual will look like, as different to the data collection form, which you're used to using. I just think it'll be an easier format to use. Next slide. So let's talk about fetal drug exposure. So we collected fetal drug exposure historically under the syndrome section. So this now in your demographics table is going to move to the pregnancy complication area. And so it's not a new field. However, it has a new definition. As you know, those of you who've been doing this for a little while, we've struggled with what the definition of fetal drug exposure is going to be. So the old definition was anything that's not normally prescribed during pregnancy, which is not a very great definition, and we know that. But for 3.41, we will continue to use that definition. Starting with 6.23.2, we're going to really refine this for the intent that we think that fetal drug exposure was intended to capture. And this is really related to the teratogenic effect on the fetus or on the pregnancy. And so that's what we're looking for now in this field. So it's only going to include federally illicit drugs, and there will be a list of examples, things like heroin, LSD, and this will also then include the use or abuse of prescription drugs where you don't have a prescription or where you're abusing the drugs that perhaps you have a prescription for. So that will all go under one section. Next would be drugs that we know have a fetal risk, but that the benefits outweigh the risk to the fetus. This was previously called category D. So those of you who have followed any of the FDA regulations, you know that they've moved away from their categories A through D and X to categorize the drugs. They wanted physicians and their patients to be able to have some information, but also have discussion. So some of the medications that are included in category, previously known as category D, were some seizure medications and things. There may be also some opioids in certain amounts, like say a mother undergoes a procedure and needs opioids for one day kind of thing. So you may see those fall in category D. So we're looking to collect those. But no longer are we worried about A, B, or C. So you will see that mothers will be prescribed drugs in category D, and so those are what you would want to include. We've included some common examples and such as well. Then we are also interested in what was previously known as category X. These are drugs that are contraindicated in pregnancy. They would include anything that would induce abortion, obviously, and then other things like Accutane. So known to have severe risk to the fetus, and we would never want anyone to take these drugs. And so this is all we're looking to collect. So anything else that would have been previously Schedule A, B, or C, we're not collecting. Federally illicit abused prescription drugs would include things like, benzos, opiates, things like that. Drugs with fetal risk in previous category D, and those severely contraindicated in pregnancy or category X. So the FDA rules changed somewhere in 2015. So your old drugs that were all approved by the FDA prior to 2015, you can still find in those categories, A through D and X. Anything that was approved after 2015, you're not going to find in the list anywhere. We've provided then links to FDA websites and medication websites where you can find some of this information, because now you may need to be looking up specific drugs that the mothers are taking while they are pregnant. So we provided those links within the training manual so you can go out and find the answer to this. Of course, if you have questions, please submit it to the core group, as we can always help you find the drug information and then update the training manual if we find it needs to be updated. The other thing I would say is, as I looked up a few examples of things that I know commonly I see in our charts, the drugs that approved after 2015 that would have been in category X, when you go to their drug inserts, you will see the great big box that says do not take if you are pregnant. And so the information is there. We just may have to do a little bit more work to get to it for newer drugs. Next slide. Okay, so as we look at maternal smoking, again, this was a new field as well. And this is going to be defined as a documented smoking of any substance during pregnancy. So this will include tobacco and marijuana. So it's anything that you would smoke. So it could include illicit drugs if you're smoking those as well. This is really looking at, a fetal exposure to smoking. This is different from the preoperative factor of tobacco use. So again, treat every field as a separate field and know that there will be not contraindications in the, between the definitions, but that each one of these fields, depending on the section of the database that's in, is looking to collect a different piece of information. So you've got to really look in the training manual and follow exactly what the training manual is saying to do. For fetal alcohol exposure, so this is very different from fetal alcohol syndrome, which is collected under syndromes and will remain under syndromes. And so this is that you have any documented alcohol exposure during the pregnancy. This baby may or may not have fetal alcohol syndrome, which has its own definition. But we know a lot of people submitted questions to the core group about, well, I have a mom that had a documented history of drinking this much during the beginning of the pregnancy or during the entire pregnancy. However, the baby wasn't identified to have fetal alcohol syndrome, and there was nowhere to otherwise collect that alcohol exposure. So now under pregnancy complications, you will be able to collect it, and it's any alcohol exposure whatsoever. Next slide. So let's move into then the non-cardiac congenital anatomic abnormalities, otherwise known as NCAA, because it's much easier to say. There are only two new fields that have been added to this, and this is kyphosis and lordosis. And this again came from people writing in free text other. And so we were able to add this to the list. What I do want you to see here under the intent clarification, which is where all the definitions are, is that we're looking for a documented clinical diagnosis to code any of these. And then if there's something that's not included in the list, of course, we have field 930, other, and then you can specify using free text in sequence number 425 what your other NCAA is that you're referring to. And again, STS looks at those to come up with what needs to be included in this list. I think one caveat here that may have not been explained very well in the previous training manual, but we're looking to expand the definition here is, while NCAA, the C stands for congenital, non-cardiac, I like, congenital anatomic abnormalities, just understand that that while it may be present from birth, the diagnosis may not be made while in utero or at the time of birth. So something like pyloric stenosis, which is in the list, may not be determined until the baby is actually fed, which is later. It could be prior to the operation or even post-operation, depending on the lesion and the clinical status of the patient. So that does not mean that you wouldn't code it, because pyloric stenosis is something that someone is born with. You just might not have the symptoms to even know to be looking for the diagnosis until the child is fed. So again, pay attention to all of the definitions. NCAA, there weren't any major changes at all, maybe just some clarifications based on questions we received. Next slide. So syndromes. You're going to see this repeat in both the syndromes and the chromosomal abnormalities. And I know there's been some confusion in the current definition of how these should be documented in your electronic health record. We understand that sometimes, especially in older patients, that the genetic testing and diagnoses that support some of the syndromes and chromosomal abnormalities were done previously at an outside hospital, maybe even at your hospital, but prior to your records being all electronic and things. And so the syndrome or the chromosomal abnormalities get carried through as with your clinicians documenting that, at birth, this testing was done and these were the results, or, received a call from the birthing hospital that said these were their laboratory results. So we understand, especially in older patients, that it may be difficult to have the actual lab values on hand. And we're not trying to tell you you can't code those. So the point is, you have documentation in the patient's medical record of laboratory results or the clinical diagnosis by a provider that is saying, here were the results of genetic testing. So what you're not doing is saying there's suspected syndrome or suspected genetic abnormality. You actually have a clinical diagnosis of something. You just may not have the actual laboratory supporting results in hand. The other thing I'd like to add with syndromes is any associated physical or anatomic abnormalities can also be captured in the NCAA section. So when you look at patients with vaterovagal syndrome that have an associated tracheoesophageal fistula, we would want to go back to the NCAA section and also select the tracheoesophageal fistula as well. Next slide. So again, chromosomal abnormalities, testing could have been done in an outside hospital, previous admissions, anywhere. We're looking again for a clinician to document the test results wherever those may come from, or even a phone call from another hospital, provider to provider conversation, something like that. All right, next slide. And so otherwise, syndromes and the chromosomal abnormalities, no major changes to definitions and things. One question we do get over and over is the Duchenne muscular dystrophy. Should that include other types of muscular dystrophies? And the answer there is no. And this is laid out in the training manual that it is specific to Duchenne muscular dystrophy only. You can put any of the other muscular dystrophies under other and free text those in, as well as SMA has been updated to be all types of SMA. It used to be, I think, SMA type 3 only, and it actually has been expanded, the definition's been expanded to include all types of spinal muscle atrophy. Okay, preoperative factors, we're gonna spend the most time here since I think there have been, quite a few changes to this section. So what you're going to see in this section is that many of the preoperative factors are now delineated by surgical age. And by that, I mean whether you're older than 18 or younger than 18. In the training manual, as well as in the data collection form, it'll say age in days is greater than or equal to 6,575. That's how you know you'll only be collecting that for the adult patients, versus if there's no age after the factor, then that means it's for everybody. And then of course, if it's pediatrics, it's going to say less than 6,575 days. So that's how you'll know. Your software should also help you based on when you put the date of birth in and it does the calculation of age, only be able to show you those fields for above, below, or both age groups. You will also note that there are updated and clarified definitions. We know that many of us, Leslie and I included, that we struggle with some of the definitions and trying to see if something really fits or doesn't fit. What's the intent of this field? So we're hoping that we made this very clear to you. So if you look at the picture that I've included here, this is just an example for liver disease. This is a field that came over from the adult side. And so again, you're only going to answer it for patients that are age and days greater than 6,575. There's a clearly defined definition. What are we looking for with liver disease? Again, hepatitis B, hep C, drug-induced hepatitis, autoimmune hepatitis, on and on and on. That's exactly what they're looking for. Did you have documented liver disease between birth and OR entry date and time? So that's your time frame that you're looking for, not after OR entry date and time, because this is a preoperative factor. So anytime between your birth or OR entry date and time, and you're going to code this factor if, and that's how every preoperative factor is set up, with a definition, a time frame, and a code this factor. Some of these are going to be really long. Code this factor for this, and this. It does not include ABC, XYZ. Here are some examples. Some of these may be really long, but we're hoping that they provide the clarity that you need, especially in the adult brand new field that we've never collected before. To give you as many tools as you need. Of course, please continue to submit your FAQs as you start collecting this information. And I know Melinda is going to help us out tremendously with these adult fields that we are not used to collecting. In addition to the general preoperative factor list, there are now some child fields or daughter fields, if you will, of some of the adult fields than anything. Endocarditis, though, for everyone now has, if you select endocarditis, you're then going to have to say, is it active endocarditis or is it a history of treated ever in your lifetime endocarditis? And so again, definitions clearly delineated for what we're looking for in those fields. Additionally, there are some other fields for the adult patients that fall under this preoperative factor and also include lab values and medication use. Next slide. So one thing I do want to add, and this came from a lot of feedback and FAQs that we get to the core group, but the timing for meeting a preoperative factor. So we know in the past, we have said, if you met this factor, within the specified time frames, I'm going to just say 24 hours for an example, but then the patient's lab values improve or clinically they improve, no longer can you take this preoperative factor or code this preoperative factor because the patient improved and they no longer have it when they're entering the OR. In many of the fields, we've decided that if you ever met the criteria in the specified time frame, your risk still exists, even if we were able to pour in, some blood or medications or treatments and things. And so we still want to give, if you will, credit for the illness to the patient within the specified time frame for the preoperative factor. So here is an example of one of these. So patient meets the criteria for sepsis within 48 hours prior to entering the OR. However, they clinically improve about 12 hours prior to entering the OR. You're still going to be able to code the preoperative factor for sepsis, even though the patient improved. And so you're going to see this with hepatic dysfunction, renal dysfunction, and some things like that. If you had renal dysfunction, within 24 hours of entering the OR, and let's say miraculously your creatinine, improves a few hours before you go in, because the patient met the criteria for renal dysfunction within that 24-hour specified time frame in the definition, you're still going to be able to code the factor. Every factor where this matters or where this has been changed is clearly spelled out in the definition in the training manual. So you will see that. Next slide. So let's look at shock. So persistent at time of surgery. One of the beautiful things about the shock definition is that we have shock persistent and then we have shock resolved. So you don't have to worry about if the patient's shock resolves right before they go into the OR. You have another factor to code. So you won't see the time period change for these two particular preoperative factors. But when we look at shock, we've updated the definition a little bit. So shock is defined as a state of inadequate tissue perfusion. The time frame is that it must be present at OR entry date and time. Code this factor if both of the criteria below are met at the time of OR entry date and time. So the first criteria is that the patient's clinical condition is characterized by signs and symptoms of inadequate tissue perfusion when the cardiac output is insufficient and the patient has at least one of the following at OR entry date and time. And so there's lab values as well as cardiac index, as well as inotrope infusions. So again, the patient has to meet number one and then one of the bulleted list items from number two before you can code this factor. So I'm hoping that this makes it much easier than previously trying to determine the definition for shock or shock result. So obviously if the patient met this and then it resolved before they went into the OR, you would hit the other preoperative factor of shock resolved prior to entering the OR. The definition is the same, with the exception of it resolved before they went into the OR. Next slide. All right, so gastrostomy. The definition here hasn't changed. I think it's gotten a little more robust. So again, we're really looking at the presence of a long-term feeding tube that has been surgically or percutaneously placed directly into the stomach. G tubes are not the same as nasogastric tubes or nasojejunal tubes. The tube must be present at OR entry date and time. Code this factor if the patient has a gastrostomy tube present at the time of OR entry. The intent is to really capture a true gastrostomy tube where there is a stoma. We're not intending to look at long-term feeding through an NG or NJ. So do not include patients that have an NG or NJ tube. This field, the intent of it is not to look at long-term feeding and such. It's really that the patient had a disorder of feeding that really required the placement of a long-term tube, as in a surgically placed or percutaneously placed G tube with a stoma. So again, we got a lot of questions from data managers. We pondered this and really looked at what the intent of the gastrostomy preoperative factor was. And it's not to capture the need for long-term feeding through a tube, but it's actually that you needed to have another procedure to have a surgically placed or percutaneously placed tube for the patient. Next slide. Hepatic dysfunction. So we got a lot of feedback on this field, and I hear you that I think it's very hard to code hepatic dysfunction. When I am helping a new data manager, it's one of the things that I point out that in all of my years, and I won't even tell you how many that I've been working with the STS database, I don't think I've ever on an index operation had a patient that I was able to meet the definition or the criteria for hepatic dysfunction because it's quite strict. And so what we did add was anytime within 24 hours prior to OR entry date and time, we added if the patient is listed for liver transplant at the time they're entering the OR, or they develop at least two of the following factors, which those factors are the same. The albumin, prothrombin, and total bili lab values are all the same. But what we know that if you're listed for liver transplant, you clearly are meeting a definition of hepatic dysfunction. Again, we tried to include examples where we received questions regarding hepatic dysfunction. So if you only meet one of these criteria, that's not good enough to code hepatic dysfunction, one of the lab values, and do not include patients who meet the above lab criteria to correct hypoalbuminemia that's not related to hepatic dysfunction. So hopefully we've clarified using your previous submissions of FAQs. Next slide. Coagulation disorders. So when we get to the coagulation disorder, hypocoagulable state secondary to medication, we've now specified meds and their associated lab values. And so one of them would be you're taking Coumadin or other meds that are known to impact your prothrombin time, and you have a prothrombin time that's above normal. Or another example is the patient's taking aspirin or another antiplatelet or antithrombotic medication that impacts platelet function, and the platelet count is less than 100,000. One thing that we did add in is that you're really looking at, systemic meds. So it is not heparin to keep a vein open, like perhaps a vein or artery open, like where you're running, small doses of heparin to keep your art line open and things like that. That is not going to induce a hypocoagulable state secondary to that medication. So you would select the other factor of a hypocoagulable state, not secondary to medication. So again, you'll see in the definition's quite long, so I didn't include it all here, but these are the big changes, is that you're going to be looking for specific medication groups or types of meds that impact specific lab values in the clotting cascade. Next slide. Tobacco use. So thank you to the adults who let us know that under their definition of tobacco use, that most products that are vaped contain tobacco. So we've included in our definition now that we would include, smoking as well as all vaping. So thank you to the adults. They also gave me examples of other ways that you can get tobacco products other than traditional smoking. And these are things I had to look up because I don't understand. But orbs, strips, sticks, and hookah use, as long as it's tobacco that is being smoked. It doesn't matter how you're getting tobacco, cigarettes, cigars, pipes, chewing tobacco. So again, this is very different than maternal smoking in your pregnancy complications, and does not include that or secondhand smoke exposure. So again, use every definition separately because these are all, would be analyzed a different way. Next slide. A new field to us in the preoperative factors is chronic lung disease that is not associated with premature birth. And the first question Leslie and I had when we started looking at this was, does this include things like asthma, pulmonary hypertension, or tracheobronchomalacia? And the answer to this is no. We have a different field for asthma. So whether you're an adult or child, we've got definitions for you if you have a diagnosis of asthma. But this will not include pulmonary hypertension or tracheomalacia, bronchomalacia, or tracheobronchomalacia. Again, clearly spelled out in the definition in the training manual. Next slide. So in summary, I know that this is a small bolus, but the training manual will get posted. We do have some outstanding meetings and questions with both Dr. Subramanian as well as some of the adult fields we need to work with Melinda and an adult surgeon with to make sure that we have everything covered before we post it. Please note the updated definitions. As I pointed out in the preoperative factors, many of the existing fields have clarified or updated definitions. We will not be posting your individual questions. The FAQ process will happen the same way. You'll still submit it to the box and ask your question. You will get an answer the exact same way as well, emailed back to you personally. However, we're not going to post every individual question into the training manual. We know that that added to hundreds and hundreds and hundreds of pages in the training manual. We also then have to worry about if we answered a question 3 years ago and we're still using that version today, there could be a different flavor and a different intent. And then we know it's confusing. If I go back 3 years, it says this. If I go forward 3 years, it says that. What is the correct answer? So we want to get away from that, and it's kind of some version control, if you will. We will have a separate document posted when we start answering FAQs related to the training manual or any updates that are going to be made to the training manual. So again, you won't have to go searching or there'll be surprises that you didn't know about. In the training manual, there'll be this separate document that says, under this field, we added this. But otherwise, the individual questions are not going to be posted. But again, you'll get the same answer. The process will be the same. We're just not going to clog up the training manual with a bunch of individual questions. If a definition needs to be updated, you bet that we will update it in the training manual and put it in that document that you can see each month in case there are any big changes. We are always, always, always available for help. So if you have burning questions now, please submit them. Obviously, we're on this call and we'll answer questions today, but submit them to the FAQ box, and Leslie and I will get them to the appropriate people if we can't answer them ourselves. So, questions?
Awesome. That was a great presentation, Chastity. So yeah, we do have questions. Before, Kelly wanted to know if you could go over the chromosome slide again. So I'm gonna scoot back. Wait, where is it? This one? I think chromosome slide again.
Okay. So the definition will read, if chromosomal abnormality is known, code all of the documented chromosomal abnormalities, including those that were diagnosed during prenatal testing. Documentation must be contained in the patient's medical record. This may include genetic testing, lab results, or the documentation of a diagnosis or lab results by a provider, including those that are coming from outside hospitals or outside labs.
I think that was the right slide. Yeah. Okay. Kelly, if you have specific questions, just let us know. I hope that was the one you were referring to. All right. Let's see here. All right, let me get back here. Sorry, guys. Before we get back into other questions, we have about 15 minutes. Our next call, our user group call is June 6th at 12 Central, and our monthly webinar is June 20th. Again, contact information. And let's just get back to our questions. We don't have a lot right now, but our next question, Chastity Leslie, is from Mary. Will maternal vaping be included in the maternal smoking pregnancy complication?
Maternal vaping be included in the maternal smoking pregnancy? Yes, Mary, great question. The specific definition says documented smoking or vaping of any substance, including but not limited to tobacco and/or marijuana. So thank you for that question. It's clearly delineated in the training manual you just haven't seen yet.
Perfect. Thanks, Jeff. Next question from Janet. Since these fetal drug exposure was part of the risk model in the syndromes area, will it still contribute to the risk model?
Correct. The field has just moved to a different location in the database because fetal drug exposure is not really a syndrome, if you will. And so it just moved to a different area, but the field will still be included in the risk model.
Right. And I think Becky had the same. For risk model cases entered in 341 and prior, will the syndrome fetal drug exposure still be included, or will it be removed since it's no longer in the risk model for the new version?
Same question with a different flavor. It will be included no matter where the field lives, and even though the definition has been clarified. So in 3.41, old definition, anything that was not normally prescribed would not be normally prescribed during pregnancy, and it lives under the syndrome section, versus 6.23.2, it moves to the pregnancy complication section with a new definition of looking at truly the teratogenic impact, and would still be included in the risk model. Yes.
Perfect. Thank you. Next question from Terry. If kyphosis and lordosis occurs later due to musculoskeletal disease disorders such as CP or MD and is not congenital, do we still count it?
That's a great question, Terry. And it is not spelled out in our current definition. Why don't you go ahead and submit that so we can discuss it and see what we want to do with that, and we can get it out before the training manual even rolls out. Terry, that's a fantastic question. I know we do have a NCAA of scoliosis, but lordosis and kyphosis were new additions. And so I think that we need to clarify if they're diagnosed later, should be included.
I don't think she can submit 6.2, 3.2 questions yet. Has that?
Oh, like in the FAQ box?
Yeah, in the FAQ box. Yeah, so I just have to email it to.
That's fine. Or, I mean, you can include it under 3.41, the heading, and then we can just put in your question, this is related to 6.2, 3.2.
Yep.
Does that work, Leslie?
Yeah, I'll pull it out. Thank you.
Perfect. Can you please share this info with the audit team regarding syndromes and chromosome abnormalities? So yes, Janet. Absolutely.
Absolutely.
This presented today, though, is for 623.
Right.
So it will apply to audits for 623.
Right.
Yes. Yes.
Let's see. Next question from Dawn.
Chronic lung disease not related to prematurity. We saw what isn't included, but what is included. So this came over from many definitions for chronic lung disease for adults, and we're really looking at parenchymal type lung disease. So there are things such as specific pulmonary function testing results, the use of chronic oral or systemic steroid therapy for documented lung disease. Let's see, some ABG values, documented chronic lung disease diagnosis that's not related to prematurity, and then more related to pulmonary function testing, diffuse capacity of the lungs for carbon monoxide, known as a DLCO, and then specific values for that. So that's the major definition. And then it also goes through and says, you know, sometimes people with, you know, things like asbestosis, black lung disease, pneumoconiosis may qualify as long as they have an actual diagnosis in the chart, things like that.
Thank you. So Kelly was saying, yes, that was the slide for chromosome. Ongoing dilemma is whether to include chromosome results based on physician progress notes, but without the actual results from the lab.
Right, and we understand that sometimes what gets carried through a chart is, you know, a patient has a, you know, whatever, P2.35 deletion, and that just gets carried through the chart, and you may not actually have the result from the lab. That's okay. You have a clinician diagnosis saying this patient has a known chromosomal abnormality, and this is what it is. It's not we're ruling out, or we think there is, or suspicion of, but the clinician is clearly documenting that there is a known chromosomal abnormality, and this is what it is.
Thank you.
Sure.
Carla, how do I get included in the email list so I can receive invites for future webinars? I am looking, sorry, I've got the new website up here. I'm looking, we used to have a link. Again, I'm sorry, we're all getting used to the new updates on the STS website. And I know there used to be a link where you could fill out your information to ensure you are on the list for webinars. I don't see that now. So let me reach out to marketing. So Carla, if you just want to email me directly, I can get you in touch with the appropriate team to get you added to the list. And I'll put my email in the chat box. CS.org. Okay, perfect. And I'll get back to marketing to see if they can get that link added back on the website. So I'll talk to them about that. Okay, is there a way for STS to provide a static link to the training manual and have that always go to the most current version so that we can just reference that and not go and download the latest version of each month?
Oh, hey, Leanne, I actually know the answer to that.
Yes,
Because
ma'am.
Carol and I have discussed this at length. And at this time, there is no way to do that, although it's on the back burner and we're looking at ways that perhaps we could do it, but we just can't do it right now.
Okay, perfect. But
Thank you,
great,
Melinda.
thank you. Yeah, thank you for the feedback, Sam. We appreciate it. And apparently Melinda and Carol are on top of it. So we're working on it. Heather, can you please reiterate the updates to the analysis overview? So yes, the only thing that was updated in the current analysis overview that from the previous version was just the primary procedure and primary diagnosis section. So I went in and I added all the harvest codes within the rules for all the procedures. And then we added the 5,000 codes that were now considered in the PSFs. So that's the only change from the previous version, with the exception of some minor grammatical updates and things like that. So the only section that you need to go back and refocus on is just the primary procedure rules determining primary procedure. And I'll look at a way from what Janet from feedback that others have provided. Next updates, maybe just highlighting the section that was updated. So you'll know where to focus. Sarah provided a link to the webinars. Thank you, Sarah. Thank you, Dawn. And the participant contact form, thank you, Jody, is there if you, so Jody has provided a link to the participant contact form. And yes, the slides from today will be posted on the STS website. Again, they'll be here under the congenital heart surgery database section, under the CHSD webinars, and the most recent webinar recording and slides will be posted here. So yeah, so after today's call, David, I'll send it over to marketing. They'll need to curate it. And so give them, we ask usually about 48 hours. So they'll go and curate the video, get it posted, ready for posting. and post the slides. So Angie, you're having trouble downloading the training manual. Yes, the website has changed. So if you are using any previous links or any previous bookmarks, you'll need to delete those and go back to the new STS website and create new links or bookmarks, clear your cache, clear your cookies, all those. If you're still having issues with the new website, just please email us at stsdb_helpdesk@sts.org. Does this webinar not exist anymore? So
This website.
you'll likely find the previous webinars are on our YouTube channel. So let me go back
No,
here.
she's talking about the website.
Oh, sorry.
No, you're fine.
No. So no, yeah. Any previous links or anything that you have, I would delete those, put in sts.org and create your new links. Sorry, thank you. So yes, Mary, I agree. Chastity's educational webinar is phenomenal. She does a phenomenal job. She's a great teacher.
Mary, thank you very much. I
Kudos to
appreciate that.
Chastity and they do an amazing job teaching. All right.
And
Yes.
one quick note, just for everyone's knowledge, the training manual is generally posted the first week of the month. Although we have gotten a large number of questions coming in addition to other questions about reports and other things. So the last couple have been around the 9th to 10th of the month. But in general, that first week of the month, all of those FAQs will be in the new training manual and posted.
Thank you. All right. Yes, and if you have any issues accessing the website or anything as such, please email us at stsdb_helpdesk@sts.org. And I did put that email address into the chat box. And Janet, can I share the Z-score calculator link? Yes, you may. All right. Let's see. Any other questions? This is Janet had sent a question to the help desk regarding the Z-score calculation that happens in analysis. And this is the Janet has put the information into the Q&A. So I'll leave that there in case anyone wants to copy or paste that or wants to snag that information. So that information is found there. All right. Any additional questions? We've got just a few more minutes. Chastity, Leslie, anything you guys can think of that we may have that we need to share? I don't have any additional information.
Nope.
I just want to reinforce that Leslie and I and Leanne and Dr. Subramanian are working really hard on the training manual and just trying to, before we go out of the gate, have everything as clarified as we can. So thank you for your patience. We appreciate it. And just know that this work is like around the clock happening right now. We're even chasing Dr. Subramanian out of the country.
Yes, absolutely. We are literally. So, and Mayori wanted to ask Janet if she could paste the formula again. So, but thank you all for joining. I'll leave the Q&A up for a second. Mayori, if Janet wanted to post that calculation for those that wanted to just hang out and snag that, I'll keep this live for just for maybe another minute. But thank you. Oops, Chastity, Leslie. Wait, someone had their hand raised. I'm sorry. I saw it. Just saw it now. I apologize.
Oh, whose
Hold on.
hand raised? I'm sorry.
Oh, it was Janet.
Oh, I'm sorry.
I'm trying to unmute you, Janet, but I can't. I'm sorry. I don't know why I'm not able to unmute you. It's not letting me. And I should have the permissions. Let me see here. Let me see, Janet. Oh, you can't post the picture of the calculation. Okay.
Hey, I think I'm
Oh,
unmuted
there you are.
now. Yeah, I can't do I can't copy and paste into the Q&A.
Okay, hold on. Let me, I don't know if you can do it in the chat. Let me see. See if you can put it in the chat. You should be able to do that. Have access
Okay,
to
I'll
the
give it
chat
a
now.
shot.
Let's
Thanks.
see if it'll, oh yeah, we'll see if it'll work.
That's the link, but they also sent a little screenshot of the formula, and because I think it's a picture, it's not posting. But the link is there, and that is the link that they use to do the calculations. So folks can use the same calculator as STS uses to sort that out, because I was challenged by that. Thanks.
Thank you so much, Janet. I appreciate that. All right. Excuse me. All right, everyone, let's see here. Oh, thank you. Thank you, David. Thanks, Chastity, Leslie, for your phenomenal education as usual. I hope everyone has a great rest of your day. And if you need anything, just reach out to me directly. Thanks, everyone.